Welcome to Eye Contact. I'm Dr. Sebastian Wolf. Ocular steroids play an important role in the treatment of retinal diseases. New research suggests that steroid therapy targeting specific receptor implicated in edema holds promise. We are discussing this research with Professor Francine Behar-Cohen, director of a team at the French National Institute of Health and Medical Research in Paris, and professor of ophthalmology at the Hotel Dieu. Welcome, Dr. Behar-Cohen. Let's start by reviewing the current use of ocular steroids and the problems we would like to overcome. Tell us about your work. I understand you are looking closely at three specific areas of retinal tissue: in retinal glial cells implicated in edema, the retinal pigment epithelium, and choroidal vessels.
Yeah, thank you very much. Indeed, me and my group who are working since years in understanding how steroids work. It's very interesting to see that, in example, we are using steroids inside the eye in case of diabetes, which would not be possible to use them in the systemic use. It would aggravate the disease. This just shows that you really have different action of steroids inside the eyes compared to use them systemically. And very few research finally have been conducted since years to understand what are those molecules doing, first of all, in physiology, and then how do they act? Because of course it's fascinating to see that you have molecules, you have steroids that work on so many mechanisms. They are anti-angiogenics, even if they don't work in AMD, an example. And why? Because they are very strong anti-angiogenic agents in other fields. They are anti-edematous, they are anti-inflammatory. And it's interesting to see, first of all, how it works. Because if we understand how it works, maybe we can optimize the molecule to create a molecule that would be, an example, more potent anti-edematous, but do not have effect on ocular tension, an example, or be more anti-angiogenic, and why they are not anti-angiogenic in AMD. So this is all a very wide field of basic research. And actually, this research is also ongoing with the mineralocorticoid receptors, not only in the field of the eye and the retina, but in other fields of medicine, where now it's very clear that you have two types of receptors. And if steroids bind to the glucocorticoid receptor, they are rather having these anti-inflammatory effects. But if they are binding to the mineralocorticoid effects, they have very bad pro-inflammatory effects, vascular effects, cardiac bad effects in the brain. And so we are really looking closely at what are the differential effects in the eye regarding also their pro or anti-inflammatory effects, pro or anti-edematous effects. And we hope that with this we are going to improve the use of the steroids.
And do you think steroids are mainly necessary to inject into the eye, or could we do some systemic treatment with the different steroids, or what's your view there?
Yeah, this is a very interesting question, and for now, all the work that has been done before was looking at optimizing the anti-inflammatory effect of steroids, but reducing their kidney effects. But indeed, by changing the molecule, we may think that we could use them systemically and have almost no of those bad effects also on the metabolism, and maybe maintaining an effect into the eye, because they go quite quickly and straightforward into the retinal cells, even using the systemic route.
Yeah, you mentioned the mineralocorticosteroids, and let's talk about your research focusing on optimizing the use of these steroids in the treatment of central serous choroidopathy. I think this is a very interesting field and high demand in ophthalmology we have.
Yeah, so by looking at the beginning, we were not looking at the treatment for CSCR at all, but we were looking at what happens if you overactivate the mineralocorticoid receptor specifically into the eye. And we end up with a phenotype that was very similar to CSCR. So that's why we went to try these drugs in CSCR with the drugs that were available at the time we began this research. And they are not optimized for the use in the eye as well. That's why we have some effect, maybe not the optimal effect, and there is some work to do here, probably for the drug delivery. It's not like other steroids, they do not penetrate well inside the eye. So it's good that we can give them orally, but it may be not optimized. But more fascinating is that what we've been observing in CSCR might be also possibly used, their effect in drying the retina might be also used in other disease. It's not specific to CSCR. And most of our research now is concentrating, and this is, I want to acknowledge my colleagues, particularly Min Sao, who is a brilliant scientist doing all this work with me. And we are analyzing all the targets in the retinal tissues. And I think this is going to give some interesting new results.
And you think there's a development of these drugs to be given as eye drops or to inject into the eye, or what's your vision there?
So we have developed some implants and microspheres and evaluate them in different animal models. And we also, with some of my colleagues, have been developing some drops that now we are beginning to test in humans. So it will take some time, and we're trying to have partnerships with the industry to go in this field. Yeah, the good advantage of these drugs is that first of all they are optimizing the natural steroids to bind to their receptors, and they do not induce any cataract or raise in the pressure.
Okay. And so, clinical studies, how far are these away? So you could use current drugs.
Yeah, so
and this is probably easier than to develop the new drug and to do the study, but maybe you can comment on this, how long we are away from first studies, controlled prospective studies.
So there is one big control study ongoing. It's the PI is Andrew Lottery, and it's going to include 21 centers in the UK. It's sponsored by the NHS.
Okay.
And they are looking at the effect of the current available oral mineralocorticoid receptor antagonists in CSCR. And so we're going to see. And if it does, I hope it's going to work. If it's not optimized way to give this drug, I think other route of administration should be developed. But the studies are here.
Okay. Could you talk about side effects of the systemic use of these drugs? So is this for every patient nowadays, or do we have really carefully select these before we can give them the drugs?
Yeah. So there are currently two main drugs available. It's spironolactone and eriplerenone, and there are others that are being developed by industry, particularly one by Bayer that is going to be, I hope, approved for kidney disease. So the difference between these two compounds is that one is more potent than the other. Spironolactone is much more potent but less specific, so there are a lot of side effects, hormonal side effects, which makes them not adapted for particularly young men, men particularly. So on the long term, it cannot be used. And the other drug has less side effects but less potent, but both drugs are inducing a rise in potassium levels, and cannot be used in association with many other drugs, and you have to check the kidney function. So, and it seems that there are side effects. A few of my patients have to discontinue the drug because of side effects.
Thank you for joining us. For more information on this and related topics, please visit us at EURETINA.org.